Most people, they think of neuropathy as it only affects sensation. They think numbness, tingling, burning in the hands and feet. That's the image most people have when they hear the word neuropathy. But here's what almost no one tells you. Your nervous system doesn't just process sensation. It runs your entire body. And when neuropathy affects the nerves responsible for autonomic functions, the ones you never consciously think about, the symptoms, they stop looking like neuropathy altogether. We're talking about dizziness every time you stand up, digestive problems that don't respond to dietary changes, abnormal sweating, bladder dysfunction, abnormal heart rate responses, and sexual dysfunction. These are symptoms that get attributed to aging, anxiety, GI disorders, cardiovascular disease, but in some cases, they have a common thread running through all of them. That thread is autonomic neuropathy. So today, I'm going to show you what it is, who gets it, what it looks like in real patients, and why it gets missed so consistently. Now, to understand autonomic neuropathy, you first need to understand that your nervous system is not just one system. It's three systems operating simultaneously. Most people, they know about two of them. Sensory nerves carry information from the outside world into the brain. Things like touch, temperature, vibration. That's sensory. Then you have motor nerves that carry signals from the brain out to the muscles. So when you decide to pick something up or take a step, that's your motor system working. Those are the two that most people associate with neuropathy. But there's a third type of nerve fiber that performs an entirely different category of function. Autonomic nerves run the operations that you never think about. They regulate your heart rate. They control blood pressure. They manage digestion, moving food through your system and triggering the right responses at the right time. They regulate sweating and temperature. They control bladder and bowel function, and they influence sexual response. Every single one of those functions is being managed by your autonomic nervous system 24 hours a day without a single conscious thought from you. And here's the critical point I want you to carry through the rest of this video. A patient can have numbness and tingling in their feet and autonomic dysfunction at the same time. Sensory nerve fibers, motor nerve fibers, and autonomic nerve fibers, they are separate and they perform separate jobs. So not everyone with peripheral neuropathy is going to develop autonomic involvement, and not everyone with autonomic neuropathy is going to develop significant sensory symptoms. Different fiber types can be affected to different degrees in the same patient. In many cases, autonomic fibers are small nerve fibers, which is one reason autonomic symptoms can overlap with small fiber neuropathy presentations. So if you watch my previous video on small fiber versus large fiber neuropathy, that connection is worth keeping in mind. Now, this is why the clinical picture can look so fragmented and why it's so frequently missed. So let me show you what autonomic neuropathy actually looks like in patients. The first pattern is dizziness when standing. This patient sits in a chair and feels fine. They stand up and immediately they get lightheaded. The room doesn't spin, but they just feel unsteady. Some grab the nearest surface, some have had near falls. It usually passes in 30 to 60 seconds, so it just gets written off. Their doctor checks blood pressure sitting down. It looks normal, and the appointment just moves on. What's happening is called orthostatic hypotension. When a healthy autonomic nervous system detects change in position, it adjusts vascular tone to maintain pressure. When autonomic fibers are damaged, the signal is delayed or it's absent. So blood pressure drops when you stand because the system can't compensate fast enough. In an older patient who's already told their balance is declining, this often gets attributed to age rather than nerve dysfunction. The second pattern is digestive disruption. This patient has chronic bloating. They feel full after eating very small amounts. Digestion is slow. Constipation is common, although some patients bounce between constipation and diarrhea. They've tried elimination diets. They've been evaluated for IBS, irritable bowel syndrome. They have been told maybe it's stress related. The autonomic nervous system coordinates gastrointestinal motility, the muscle contractions that move food through the digestive tract. So when those signals are disrupted, the gut slows down. Food sits longer than it should. The patient feels full, bloated, and uncomfortable. This is called gastroparesis when it affects the stomach specifically. Diabetic patients are particularly vulnerable to this. But autonomic disruption, it can affect the entire digestive tract. The third pattern is sweating abnormalities. Some patients sweat excessively in their upper body and face, while their lower extremities produce almost no sweat. Others have reduced sweating across larger areas, and this creates problems with heat regulation. The autonomic nervous system controls sweat gland function, so when fiber damage occurs, some regions lose appropriate control. The distribution often becomes very asymmetric, and the response becomes disproportionate. In clinic, we ask patients, do your feet sweat? Do you notice differences in how parts of your body responds to heat? And the interesting thing is, most patients have never been asked this, and the answers often reveal specific patterns. The fourth pattern is bladder and sexual dysfunction. This is what patients typically don't really want to report. Bladder symptoms can include things like urgency, frequency, incomplete emptying, or retention. When these symptoms appear, the immediate assumption is often structural. Maybe it's an enlarged prostate, maybe it's pelvic floor dysfunction, urological pathology. And sometimes that's exactly what it is. But in a patient with known or suspected peripheral neuropathy, autonomic involvement, it warrants consideration. Sexual dysfunction, it follows a similar path. Erectile dysfunction in men or reduced arousal in women. Both can have autonomic components, and both are consistently underreported because patients assume these changes are hormonal or psychological. When a patient presents with several of these patterns simultaneously, dizziness on standing, digestive slowing, sweating changes, bladder symptoms, or sexual dysfunction, the clinical picture begins to suggest something systemic rather than four unrelated organ problems. This is one of the most important parts of this conversation. Autonomic neuropathy gets missed consistently, not because clinicians aren't paying attention, but because patients don't experience their symptoms as nerve symptoms. Think about it. Nobody walks into a doctor's office and says, "Hey, I think my autonomic nerve fibers are malfunctioning." They say things like, "I get dizzy. My digestion has been off. I'm always constipated. My bladder, it just feels different. My heart races for no reason." So each symptom gets evaluated through the lens of the organ system it appears to belong to. Dizziness will go to cardiology. Digestion will go to gastroenterology. Bladder issues go to urology. And sometimes those referrals are exactly right. The workup is necessary and appropriate. The specialty evaluation is warranted. But when those evaluations come back without a clear structural explanation, when the heart checks out, the GI workup is unremarkable, and the urological examination is normal, the possibility that a shared nerve fiber class is involved in multiple symptoms often doesn't make it back into the conversation. And that's the gap. Of course, it's not negligence. It's a gap in how symptoms get categorized when they first enter the system. Autonomic neuropathy has well-established causes. Diabetes and prediabetes are the leading causes globally. Chronic elevated blood glucose is toxic to nerve fibers, and autonomic fibers are amongst the first that are affected. This can occur in patients with only mild metabolic dysregulation, even before a formal diabetes diagnosis is made. Autoimmune disease is another significant category. Conditions like lupus and rheumatoid arthritis, amongst others, can directly involve autonomic nerve tissue directly. And neurodegenerative disorders, things like Parkinson's disease, they frequently involve autonomic dysfunction as a core feature rather than a secondary complication. Certain medications like chemotherapy agents and cardiac drugs carry documented risk of autonomic involvement. And a meaningful percentage of cases are just idiopathic, meaning no identifiable cause is ever established. The symptoms are real, the nerve dysfunction is measurable, but the origin remains unclear. If you recognize yourself in any of these patterns, the most important thing I can tell you is this: do not self-diagnose. Autonomic neuropathy symptoms overlap with a wide range of other conditions. Dizziness can in fact be cardiovascular. Digestive issues can be structural. Bladder changes can be urological. Symptoms alone don't confirm autonomic nerve involvement. What they do confirm is that a thorough evaluation is warranted. The evaluation should include a detailed symptom history, appropriate lab work to assess metabolic and autoimmune contributors, and when the clinical picture supports it, autonomic testing. Understanding whether autonomic nerve dysfunction is contributing to a patient's symptoms, it matters because it can help guide appropriate evaluation and management across systems. Now, of course, it doesn't replace specialist evaluation when that is indicated. It basically helps to connect the dots. There's a version of your life that you remember. Not perfect, but functional. You stood up in the morning and nothing happened. You ate a meal without discomfort for the rest of the day. Your body ran quietly in the background the way that it's supposed to. That's what patients describe when I ask them what they want back. Never dramatic reversal, just the ordinary experience of not having to think about their own body constantly. Autonomic neuropathy is one of the least discussed presentations in the entire neuropathy space. It doesn't look like the textbook image. It fragments across systems. It gets attributed to other causes, and patients often carry these symptoms for years without anyone connecting them. Understanding that autonomic nerve fibers exist, what they do, and how their dysfunction presents is the starting point for a different kind of clinical conversation. You have to keep learning. The more you understand about how your nervous system works, the better equipped you are to ask the right questions.